is a MCH alumni and also alumni of Sankara Nectal and SSDN. So I would like to request Dr. Satyendra sir or Dr. Abhijanandik sir to join the thread. And Dr. Nilanjan Kaushik Thakur, you can please add some up to continue this train. Thank you.
Okay, if there is nothing more to say, Sanjay can start his presentation.
Yes,
Okay,
yes.
you have seen that presentations? Okay.
Yes.
Okay.
We can see.
I'll go for that.
Can you make it full screen?
Yeah, I'll do.
Sanjay, make it full screen.
Yeah. So at the outset, I express my thanks and gratitude to OSA for giving me opportunity to take part in this webinars. Today, I will talk about these neuro-ophthalmic examinations. It's a huge topic, and I think without wasting in time, I should straight away go to that presentations. So first thing is the history taking. Like any other disease, history taking is the most important part, one of the most important part of this neuro-ophthalmic examinations. We have to take the history of sudden loss of vision, gradual loss of visions, whether there's a abnormality tip of the posture, which may be due to some retinal palsy, particularly 4 and 6. And sometimes patient may be associated with some motor neuron and sensor disease, like weakness of these hands. He may get difficulty gripping hands. These are some indication of some neurological problem that may be associated with this neuro-ophthalmic problem. So this is, you have to go for visual acuity and perioption SARS contrast sensitivity test. And color vision test is one of the most important part of this neuro-ophthalmic examinations. So actually, all we know that there's a two type of color blindness, congenital and acquired. And these are some differentiating point between congenital and acquired. So basically what happens in color blindness, there's a three type of pigment, cone pigments, and sputanub, deuteranub, tritonubs. So when there's a partial abnormality of this pigment, it will cause anomalous trichromatism. That is sputanubally, deuteranubally, tritonubally, depending upon the red, green, and yellow pigment involvement. If there's a complete absence of pigment, it can cause anopia or dichromatism, which may be protanopia, deuteranopia, or tritonopia. Complete absence of pigment can lead to the achromatopsia, which may be again cone or rod types. So for color vision test, two methods actually that is used for this RPD purpose and surface method. And these are plate and adjustment test. For the plate test, we are using mainly Ishihara pseudo-isochromatic plates. It is called pseudo-isochromatic because patient's impression of this card is like that, is same, consists of same color. Therefore, it's called isochromatic, which is not true. It's a false actually. That's why it's called pseudo-isochromatic plates. So this test has to be done ideally in normal daylight. So before doing the Ishihara test, reflective status of the patient has to be corrected. If patient has presbyopia, that need to be corrected. The plate has to be whole, 1 arm length, and it has to be tilted around 45 degrees. Each eyes should be examined separately, and each plate, 3 to 5 seconds are given to the patients. This plate consists of some plate. First plate is called demonstration plate, which is visible by all patients, normal as well as colorblind people. Second, from 2 to 9, these plates are transformation plates. These are actually plate which is visible by normal persons, but colorblind people will see different way. Then the vanishing plate, this is from 10 to 17. These are seen by the normal person, but not by the colorblind people. Then from 18 to 20, these are hidden plates. These are seen by these blind people, colorblind people. They see the number in this plate, but normal people would not see this. And lastly, diagnostic plates. From 20 to 25, this plate actually this plate actually identify what type of color blinded patient has, whether it's protanub, deuteranubs. Then for the illiterate people from 26 to 38, we have a tracing plate. So these actually, how these color vision plates these Ishihara plates are recorded. This is actually short version of Ishihara plate. Normally we have 38 plate, but here we have seen there's a 17 plate. It's shown here. This is the demonstration plate. Both normal person and colorblind people will see the 12, and these plates are in these vanishing plates. This is not seen by the colorblind people, but seen by normal people. These are transformation plates. Normal people will see like that, but colorblind people will see it different way. These are hidden plates, not seen by the normal people, but seen by the colorblind people. And these are the diagnostic plate. Normal people will see 26. Colorblind people will see, if it is proton 6 and deuteron 2, this is normal people see 42. It's proton, it's 2, they will see 2, and deuteron blind, they will see 4. Next is the arrangement test. Mostly here, arrangement tests are doing is FM 100U test, front short 100U test. These are sometimes actually described by this Mulson. So, and this is a Mulson color system, which is termed as a short note in PG entrance examination. So this Mulson color vision system is based on 3 things: hue, chroma, and value. What is hue? Hue actually a basic color, which represented by this is measured by the degree around the horizontal circles. And chrome or color intensity is measured by the radially outward from the neutral gray vertical axis. This is chroma. And this vertical axis is the value. It starts from the 0, that is black, and extend up to the 10 point, that is white. So FM 100U test is based on this Mulson color vision system. So what is FM 100U test? It has 4 boxes having row 22 to 23 cap with similar color hues with incremental variation of hue in each cap. Then at the polar end of each box, there's 2 fixed caps are there. These are called anchor cap. And these represented 2 ends of this hue of the color system. Then these 4 boxes represent 3 hues, 4 hues. First one is the orange magenta, next one is yellow green, third one is a blue yellow, and fourth is the purple magenta. So these are actually cap how it's arranged, and there are number in each cap which are written back of this each cap. Now, how this procedure is done? So patient is given a box where these caps are randomly arranged. Now, patient is asked to arrange this cap in a box according to ascending order of hue at a fixed time, 5 to 10 minutes. Then these anchor or the fixed cap, actually these fixed cap are taken as a reference point. So taking this fixed point or anchor as a reference point, these caps are arranged in this box. After this arrangement of this cap, recording of the variation of number of this cap, which is present at the back of this cap, already I have mentioned, is done in a scoring sheet in order of arrangement of the patients. So this is how this recording is done. This is the sheet, and every radial line represents one cap, and these circular lines represent the variation the patient has made in arranging that cap. This is a normal thing. Patient has made very little variations. So depending on the variation patient has made, there's a scoring pattern. Superior score is described when the patient make error between 0 to 16, which is found about 60% of patients. Average, actually, the variation or error is around 16 to 100, which is found in 68% of patients. And this is normally found when the patient done the test first time. Low score, if the variation is more than 100, that indicates probably patient has color blindness. These are the actually different type of pattern we may get because of variation of this or error of this cap arrangement. This is proton lobes, this is titan, this is deuteron. This type of pattern we may get in this chart. This is actually normal where variation is not much significant. This is within the normal limits. So this can be done also manually, how it looks like when it's done manually. So coming to the visual field, next important test for this neuro-ophthalmology, the require has nicely described what is visual field. Visual field is a hill of vision which is surrounded by darkness. Now, we have three different methods for assessing visual field: confrontation technique, Goldman perimetry, and simple automated perimetry. Coming to the confrontation technique, this is a very simple technique and bedside technique, but very, very useful techniques. What actually we do here, patient is an examiner seated face-to-face in a position at one distance, at the same level. For examining the right eye of the patient, he is instructed to cover his left eye and fix his gaze to a particular point of this examiner, either root of the nose or the right eye. Then patient, right. Same time, examiner also close his right eye, and vice versa. So then examiner shows the finger in different quadrant, either in the lower quadrant, upper quadrant, or in the other side also to find out any hemianopic field effect. If patient cannot count the finger, then some objects are brought from the seeing to the non-seeing area along the curve of the examiner's eye. This curve actually represents the visual field of the examiners. So this way also, this field pattern can be calculated with the help of confrontation techniques. This is how this confrontation technique field effect can be documented. Here the normal finger counting is seen all the quadrant. This is bitemporal field effect, finger counting not seen in temporal half. This is left hemianopic field effect, finger counting. Patient cannot assess the finger counting in the left side. Goldman perimetry, of course, I have never done the Goldman perimetry, but this is a very, very useful perimetry for neuro-ophthalmic examinations. Why useful? The thing is that this is a kinetic perimetry. What we do, we bring an object in a meridian from periphery in different circles. So what happened in static perimetry? What we do to static perimetry? We apply stimulus in particular point. Suppose in 30-2, we apply the stimulus at a 6-degree apart. Similarly, in 10-2, apply the stimulus 3-degree apart. If in neuro-ophthalmic, what happened? We may have some island of the scotoma in neuro-ophthalmic. If this island of scotoma less than 6 degree, that can be missed in static perimetry or 30-2. That can be easily picked up with the help of kinetic perimetry. So, second thing is that some patient who has neurological impairment, particularly hemiplegic patients or other sensory deficit, they may not do that static perimetry. They cannot press the button. In that case, this Goldman perimetry is a very useful alternative. Definitely, Goldman perimetry has a role in neuro-ophthalmic. Coming to the automated perimetry, of course, these are very familiar to us. We're mainly doing this type of perimetry, mostly 30-2. So this is one pattern of perimetry we have seen commonly in pituitary adenoma. This is a typical bitemporal field effect. This is another. Here you have seen a lesion here. This is a sphenoidal meningioma. It's affecting the fiber of the inferior nasal retina of the contralateral eye. This from a band we call as bone 11 bands. So if there's lesion or meningioma here, it can press the bone 11 band. It can affect the nerve fiber of the contralateral eye, which can result the field effect in the superior temporal half, and there will be a central scotoma in the ipsilateral. We call it junction scotoma. This is a very important question for business students. Junction scotoma, many times we have seen this come in PG entrance examination. It asks also PG examination. So this is a junctional scotoma. This is a hemianopic field effect, left-sided. We get this type of field effect, particularly in post-chiasmal visual pathway effect. Left hemianopic field effect, we get a right side. So this is a chiasma beyond, after the chiasma, we call it post-chiasmal visual pathway. So here, any lesion here or in this area will cause hemianopic field effect. Mostly this type of hemianopic field effect, we get posterior cortex, striate cortex lesions, 40 to 50%. In optic radiations, also we get this type of hemianopic field effect, 29 to 57%. And 3 to 21% may be due to optic tract or LGV lesions. Optic tract lesion also will produce hemianopic field defect, but here in 50% of cases, it is incongruous. Incongruous means field defect is not equal both sides. Here you have seen the left side, almost one half is involved, but the other eyes is almost completely spared. This type of incongruous hemianopic field defect you may get in optic tract lesions. You will get Wernicke pupil. What is Wernicke pupil? Wernicke pupil, when you apply light in the non-seeing retina, there will be no light leaves. That is called Wernicke pupil. Visual acuity remain normal. Important finding is that you may get RAPD in the contracted eye because the pupillary fiber is easily present in the optic tract. Then come to LGB. From optic tract, it goes to LGB. What type of lesion you will get LGB? LGB has two reasons. One is that the anterior portion of anterior LGB, this is with eye depicted in blue color, and this is posterior lateral as posterior inferior portion of this LGB. This portion is supplied by one blood vessel called lateral choroidal blood vessel, and these are supplied by the anterior choroidal blood vessel. These two blood vessels may affect because of embolism and thrombus. So if this anterior choroidal blood vessel get affected, this portion will be affected. When this portion is affected, it will produce a typical pattern of field defect where upper and lower cornea both sides will be involved, central portion of sphere. So we call it congruous homonymous quadrantic sector nerve. Similarly, a lesion in the anterior lateral portion will cause congruous homonymous horizontal sector nerve. Horizontal portion will be involved. So sector nerve type of field defect you will get in LGB lesions. Then coming to the parietal loop, here you have seen this lesion in the temporal loop will cause pie on the floor. Pie on the sky. That means the sectoral field defect upper quadrant of this left temporal field, contralateral eyes. Similarly, a lesion in the parietal loop will produce pie on the floor. This area is very closely associated with some very important area of this brain, which calculate the graphic orientations, right to right left dissociation, and other fine function of a person's. So any lesion here also can affect this center. So patient may have acalculia, agraphia, or right to left dissociation. Together we call it Jartzman syndrome. Jartzman syndrome again comes as a short note in physical intelligence. I've seen this. So when the occipital cortex get involved, it will cause field defect. Well, they are the macular spring. Why macular spring? Because this occipital cortex, tip of the occipital cortex, probably supplied by the two blood vessels. One is that posterior lateral or posterior cortical branch or anterior cortical branch. Again, another explanation is that this macular fiber represents a large area of the medial portion of the occipital cortex. So small lesion will unlikely cause any damage to the macular fiber. So macular gets spared in the occipital cortex lesions. Coming to the another very important part of this neuro-ophthalmic examination, pupillar examination, we have to see the size of the eye in bright and dim light, shape, reflex, direct and consensual, as well as near reflex. So pupil is supplied by the two type of muscle. We know this is sphincter pupilis, which is supplied by the again parasympathetic nerve, and contraction of sphincter pupil cause myas. So you know, applied light, this ganglionic cell will stimulate it, and the signal will pass through the optic nerve. Then it goes to the optic chiasma, where it will decussate and goes to the optic tract. And it doesn't reach the LGB. So before reaching LGB, it bypasses the LGB and it goes to the pretectal nucleus. From there, it goes to the Edinger Westphal nucleus of third nerve. This Edinger Westphal nucleus receive this fiber from both the pretectal nucleus. That will explain the consensual light reflex. When you put light here, the eye also get effect. This is because of this this Edinger Westphal nucleus receive fiber from both the pretectal nucleus. So this is light reflex, how this pupillar constriction occur following night applications. Dilator pupilis, these are radially arranged fiber around the sphincter pupilis. These are supplied by the sympathetic nerve. Again, sympathetic nerve come from the hypothalamus, higher side of the brain. The first order neuron come along the spinal cervical spinal cord. It reaches the ciliospinal or center of this Bachin velar in the superior cervical area. From there, second order neuron come, it goes to internal cardiac plexus, goes to superior cervical ganglia. From there, and enter into the brain or skull, whether it's a skull, through internal carotid artery, forming internal carotid plexus. Then through the nasociliary nerve of the trigeminal nerve, it goes to the sphincter dilator pupillary muscle through short ciliary nerve. Here, actually, in the ciliary ganglions, this unlike the parasympathetic nerve, here it doesn't synapse; it directly passes through the ciliary ganglions. So it has 3 order neurons: first order, second order, and third order neurons. So contraction of this dilator pupillary causes mydriasis. Coming to near reflex, what is near reflex? Near reflex consists of 3 components. First is the pupillary constriction, second is the accommodation, third one is the conversion. These 3 things has to be occurred same time to get the near reflex. So near reflex, what happened? The afferent part of near reflex, it's come along this optic tract, then chiasma, optic nerve, chiasma, then optic tract. Unlike pupillary fiber, where it bypass this LGB, here actually it goes to the LGB, then it goes to this occipital cortex. This is parastriate area of the occipital cortex. This is associate visual cortex. From there, it goes to the another center, supranuclear center of this, which is located at the level of thalamus or hypothalamus. Exact location is not known till now. These supranuclear nucleus actually control these 3 things. It control the adrenal nucleus. It control the motor fiber of the third nucleus. When stimulus is reached here, then it again and it stimulates the adrenal nucleus. Adrenal nucleus when gets stimulated, it's actually this cause constriction of these people as well as accommodation, because parasympathetic fiber comes from the adrenal nucleus. Then it goes to the through third nerve and the ciliary ganglion, and again short ciliary nerve to the sphincter pupillary, and then ciliary muscle of these eyeballs. 90% goes to ciliary muscle eyeball, and around 5 to 10% goes to the sphincter pupillary. Another, actually, this is when convergence one is it's come from this motor center of this third nerve. It goes along the third nerve. It's supplied the medullator. So when this supranuclear center gets stimulated by the parastriate cortex through this afferent pathway, these 3 nucleus together get activated. When these 3 center get activated, it causes these 3 axons same time, simultaneously. This is a near reflex. So this is how pupillary reflex is done. It has to be done in mesopic condition, not very bright light, not dim light actually. When you apply light, other eye will also get constrict. This is called direct light reflex. This is called consensual light reflex. Relative afferent pupillary defect, when you swing the light between 2 eyes, then if the patient has the optic nerve disease in one eye, that eye get dilated. These are some grading how this RPD can be graded. I think these are basically theoretical. You can get any textbook here. So what is reverse RPD? Here actually, if patient has only one eye, that means if one eye get atropiness or one eye become sphincter get damaged because of trauma, even that you can check this RPD. How? Suppose this is a eye where atropine is applied. If you put light here, if this eye is normal, because of consensual light reflex, other eye get constrict. So if you swing the light, swing the light in other eye, this eye easily get dilated. So that indicates this is normal. If the swinging light reflex cause constriction of this eye, that means this is abnormal eye. So for RPD, only one functional eye is sufficient. So these are some conditions we will get the RPD. Or even a large amblyopia, thick amblyopia also can cause RPD. Now we can quantify the RPD with the help of neutral density filter. How you can do this? Actually, this neutral density filter is actually a filter when you apply it in front of the eye, it reduces the entry of light inside the eyes. So this NDF, or neutral density filter, is available in 3 strengths of log unit: 0.3, 0.9, and 1.2. So for quantification of RPD, what you have to do, you have to put the neutral density filter on the normal eye. Then do the RPD. Increase the strength of the neutral density filter till the RPD vanishes. That strength of the neutral density filter which vanish the RPD will indicate this strength of this RPD. Coming to light near dissociation, again, here actually light reflex is absent. When you put the light, people is not going to constrict. But if you ask the patient to see a non-accommodative target, that means a channel search, people get constrict. This is called light near dissociations. Where you get light near dissociation, arterial reversion people, tonic peoples, aberrant regions from third nerves, perineal dorsal midbrain syndrome. So now coming to anisocoria. If the pupillary size difference more than 2 millimeter, it is called anisocoria. And 20% case, it is physiological. So most important thing is that whether anisocoria increase in dark, if it is increased dark, it mostly it is dilator muscle is affected. If it is increased in light, mostly sphincter pupil is affected. So anisocoria more in light. Most common cause is tonic addicts people. This is because of this damage of ciliary nerves, and then this is followed by aberrant regenerations. And this will cause tonic people of tonic addicts people. What will get tonic addicts people? Will get poor light reflex. There will be segmental palsy of sphincter. There will be light near dissociation. Most important thing here, you will get cholinergic supersensitivity. Normally, these people is not constricted with in 0.125 pilo, but if in case of tonic people, if we apply 0.125 pilo, people get constricted. Why this happen actually? Because when the parasitic nerve regenerates from the ciliary body, maximum fiber ultimately target to this ciliary muscles. Only small fiber goes to the sphincter. Because of high concentration of fiber goes to ciliary muscle, it will cause reverse. The max around huge number of fiber goes to sphincter pupil. So that's why when you apply even small, very light concentration pylorocopy, the people get constrict. Accommodation process will be present. Normally, what happens is accommodation improving gradually, but this pupillary problem remain for a long time. Arterial reversion people will get light near dissociation, small and irregular people. Where you'll get some condition like neurosyphilis and encephalitis and sarcoidosis. Lesion is in the midbrain, just dorsal to addenjar western nucleus near the pretectal nucleus. Perineal dorsal midbrain syndrome, it may also come as a short note in PGNTS examination. Most important thing is Collier sign, eyelid retraction. There will be conversion retraction nystagmus when patient attempt to upgaze. There will be upgaze paralysis and light near dissociations. Anisocoria more in dark, mainly you get Horner syndrome. This is because of damage of sympathetic fibers, where you get ipsilateral myotosis due to the paralysis of dilator pupil. So this will cause unopposed action of sphincter pupil. People get constrict. There will be apparent anophthalmos due to the paralysis of molar muscle. Again, also ptosis. Anisocoria due to the ipsilateral meiosis. Ipsilateral facial anhidrosis, because this face is the sweet gland of the face is supplied by the sympathetic nerve. So when the sympathetic nerve gets damaged, there may be a ipsilateral facial anhidrosis. Rarely you get heterochromis of iris. Some tests actually, these are basically theoretical things. You can detect this Horner syndrome. Apraclendin is cause constriction normal eyes, but dilate Horner people. This is because of the drug supersensitivity reactions. And this is again cocaine, which of course is not available in our place. It's caused dilation of this Horner pool. This because of prevention of reuptake of the noradrenaline from the sympathetic nerve endings. Polarization can distinguish whether the lesion is preganglionic or postganglionic. If preganglionic is dilate and no dilation in postganglionic lesions. These are theoretical things and may come in theories. Attention people who get third nerve palsy, warnings, hemianopy people already have mentioned. We get in optic tract lesions. The bare people we get in CVA or cerebrovascular accident. These are some people are saying you get head injury. Then you have to check the extraocular muscle. You have to check this any limitation presence in all the quadrant or all the cardinal position of these eyeballs. Third nerve palsy, fourth nerve palsy. This is one of very important tests, three-steps test, Parks Bilsowski three-step test. It is asked in Viva also. It's also come in theory exam. So it has 3 steps. First step to assess which eye is actually hypertrophic in the primary case. In case of left hypertrophy, the following muscle could be involved. It may be the pressure of the left eye, that is superior oblique or inferior rectus, or elevator of the right eye, superior rectus or inferior oblique. Remember, in fourth nerve palsy, involved eye is always higher. Next step is the Wilson's-Key this next step. There'll be hypertropia, whether it worsen in which lateral gaze. If left hypertropia increase on the right gaze, it indicate that either left superior oblique or right superrectus involved. If left hypertrophy increase on the left gaze, it implicates that either right inferior oblique or left superrectus involved. So most important thing that in fourth nerve palsy, the evolution is worse on the opposite gaze. We can remember the evoked. So third step, in which case head tilt actually increase, whether increase in left, if the left hypertrophy increase on left head tilt, is implied left superior oblique involvement, while if it is increased right hypertrophy left case, this indicate inferior rectus involvement. Most important thing that in fourth nerve palsy, this hypertrophy become better on the opposite tilts. That is called boot. These are some way you can remember these things. Sixth nerve palsy, this is another reason. Nystagmus, I'm not going to detail. This need another class actually. So ptosis evolution, this is basically a job of oculoplastics doctors, surgeons. Ptosis evolution, this is under Tensilon test we do in a myasthenia patient and endocrinium blood. This one is not available in our plots. Here actually how these tests are done. Neostigma tests were mainly due to rule out in myasthenia. Children doses 0.04 milligram per kg, adult 1.5 milligram. Response is evaluated 15 to 30 minutes. These are some contraindications for this Tensilon or neostigma test. Next test is visual evoked potential. What is visual evoked potential? Actually, this is actually electrical response of visual cortex in response to visual stimulus. For recording VEP, we have to apply some electrode. One is the occipital electrode, which is positive electrode. One is the frontal electrode, which is negative electrode. One is this vortex electrode, which actually this arting, this is called arting. It is either you can apply here vortex or you can apply the air loops. This is also called ground or arting electrode. So VAP may be again three types: pattern reversal VAP, pattern onset offset VAP, and flash VAP, where we ophthalmists are mainly using pattern reversal VAP. What is pattern reversal VAP? Here visual stimulus are actually a white and dark segboard which are applied alternately. Yes, you see here, this black, this become white again black. So like that alternate black and white visual stimulus are applied. This alternation or reversal is applied at a 2 per second. Or here you will get one wave pattern where you will get two negative white, and two N1 which come at 75 millisecond and N2 which come 135 millisecond. Another one is the P100, which is very important, and this P100 actually indicate whether patient has any prolongation of latency, which we see in multiple optic neuritis. So when you study a wave, you have to see the latency as well as amplitude. Latency is measured from application of stimulus to the peak of this stimulus. This is called latency, which is prolonged in inflammatory optic nerve conditions. Then amplitude is that this height of the wave from the baseline. This amplitude is reduced in some condition like ischemic optic neuropathy, NION and AION. In NION, AION, you will not get prolongation of implicit time, but the amplitude will reduce. On the other hand, inflammatory optic nerve condition like optic neuritis, you'll get prolongation of these implicit times. So pattern onset offset VEP, here actually stimulus is either off and on, but it remains static constant. These are we have mainly neurologist people, they are doing this type of VEP. Here the pattern is almost reverse to the this pattern reversal VEP of wave patterns. We get a two positive waves, one negative waves. The flash VP, actually, if the patient visual acuity is very less, we give some flash stimulus, where actually this flash stimulus is applied 1 per second. Here, it's this pattern consists of multiple negative as well as positive wave. Most important is N1 and N2, which comes 75, 135 millisecond, and this positive P wave comes at 92 millisecond. So next, of course, let us briefly outline what is the neuroimaging test we can do for neuro-ophthalmic patients. This is mainly needed to find a location, extent, affect adjacent structure, tissue composition diagnosis, and going for a planned surgical approach. So when you requesting CT scan for neuro-ophthalmic problem, some point you have to keep in mind. First important point is the slice thickening. For optic nerve evolution, slice thickening should be less than 1 millimeter. It should be 0.1 millimeter. Then only the optic nerve get visualized. But if you make such a small slice, obviously you are going to expose the patient to high radiation. Luckily, the newer CT scan machine, they do not give high radiation exposure. Contrast enhancement, of course, is needed in vascular lesions. You have to ask for what type of plan you need, axial, coronal, or sagittal reconstruction. Another important term is tissue window and bone window. I'll discuss these two important in subsequent slide. Now coming to the imaging plan, how the CT scan is done, it may be either coronal or axial. The coronal axial plan, which is actually parallel to this ridge line. What is ridge line? This line passes through the inferior margin of this orbit up to the external auditory meatus. This is called ridge line. And these axial cuts are parallel to the ridge line. But a coronal plane, which in normal CT scan, it is 90 degree to the axial plane, but in case of orbit, it is 75 degree. This oblique coronal plane only give the upper intraorbital structure visualizations. Then this is now these are some technical term. Hounsfield number. What is Hounsfield number? Hounsfield number is actually this is the quantification of this radio frequency radiation response to a particular structure. Depending on the Hounsfield number, this structural pattern become visible. So, for example, Hounsfield number of the water is 0, and for air and fat, it is -100. So this is taken as a standard one, baseline Hounsfield line. Soft tissue and other structures Hounsfield number become positive. For example, bone, it is 300 to 1000. So even if this is metal, actually more than 300. Soft tissue is 30 to 40. So now coming to the window width and window level. What is window width? Actually, this is this FRD, difference of maximum or minimum Hounsfield unit in a CT scan. Suppose if you want to do a CT scan of a soft tissue mass, then your Hounsfield number should be that particular range, then only that structure becomes visible. Here actually, this in particular, this width, Hounsfield number, lower level of this window width at the particular scan appear black. Suppose if this Hounsfield number here is 0, if this structure Hounsfield number less than 0, it will appear black in that particular scan. And this structure who has Hounsfield number more than maximum value, their structure will be appeared as a white. Window level is that actually the medium of this window width. Now coming to the soft tissue window and bone. What is soft tissue window? Bone. In a soft tissue window, Hounsfield is kept in the range from 0 to 100. That will almost cover all the soft tissue structure. And the window length is 50. That means average of these two Hounsfield number. So if you want to see the soft tissue structure, you have to ask the radiologist, I want this scan with a soft tissue window. So if you want to delineate the internal structure of the bone, then you have to go for bone window. Here, this Hounsfield number range from 0 to 800, and the average window length is 400. Obviously, at this high Hounsfield level, bone will be clearly visible because the range of the Hounsfield number is very wide, so soft tissues are not visible clearly. So if you want to see the bony structure, ask the radiologist to go for a scan for Hounsfield number in bone window. If you want to delineate the soft tissue structure from the bone, ask this radiologist to do a CT scan with soft tissue window. Then, of course, you have to ask the radiologist to do some scan which needs some modifications. For example, Valsalva maneuver. This is sometimes required to find out any keratoconcavenous fistula or vascular lesion in the orbits. Then another scan is if you want to do a complete optic nerve scan, that can be only achieved if you take a cut, which is 30 degree to the ridge line. Ridge line, I already have told you that this is the line which crosses the infraorbital margins of the orbit and external orbital meatus. So the radiologist must have the knowledge about this particular cut section. Then only he will be able to do a complete optic nerve scan. So here it is if you do a scan like that only, what will happen? Because of this kinking effect of optic nerve, this part will be visible, this part will be visible, middle part will be not visible. So if you take a scan which is 30-degree ridge line, whole optic nerve will be visible here. Of course, these are some component of CT scan. I'm not going to discuss details. And then, of course, this is step by step how you have to scan evaluate the CT scan. One by one, all the structure need evaluations. These are the axial scan. So these scans are arranged from the cephalic to the caudal to the cephalic. This is most lower part of the axial scan, and this is the most upper part. So what you'll see in lower axial scan, you'll see this is the NLD, this is eyeball, and this is maxillary sinus. This is infraorbital fissures. If you scan slightly mid-level, you'll see all the muscle and optic nerve and then eyeball structures. You'll also see supraorbital fissures, then the sphenoidal sinus. If you do upper axial scan, you'll see that this LPS suprarectus complex. Then you'll see trochlea also, which actually connect these medial supraoblique muscles. This is corneal section. This scanner arranged from anterior to posterior. If you take an anterior corneal scan, what you'll see? You will see supraophthalmic vein. This is very important landmarks. And you will see also the anterior section of the eyeball. Then muscles are also visible. Slightly posterior section will see views, this maxillary sinus as well as sphenoidal sinus. Then more posteriorly, what you'll see the supraorbital fissures. This is actually a scan of a orbital floor flexor. This muscle get entrapped here. This is called range of signs. This is, you have seen that white lesion here. This is not actually optic disc protrusion. Here you have seen that lesion is extended slightly laterally. This is actually choroidal osteoma. Optic disc protrusion will be like that. This is a localized lesions, typically seen at the optic nerve head. And this is, you have seen that this muscle get thickened. This is whole the muscle get thickened, except this tendon. This is thyroid ophthalmopathy. Another scan where only anterior 2/3 of the muscle get thickened. This is actually, if the patient age is less, young patient, it is suspected to be a myositis, or the patient is age is slightly more, most likely it is a malignancy or metastasis lesions. This is typically I've seen this skull legs here, cysticercosis, and tram track sign. You'll get optic sheath meningioma, optic nerve sheath lesions. MRI. These are some indication of MRIs. Some absolute contraindication of MRI, particularly if the patient has metallic pacemaker and cochlear implant. Particularly traumatic optic neuropathy, if patient has suspected foreign body, you always go for CT scan, never do this MRI. Contrast is needed to find out the tumor, infection, cranial palsy, and also demyelinating disorder. Now, these are the some terms used in MRI. Pulse sequence MRI. What is pulse sequence MRI? And this actually determines the radiofrequency burst, which will displace the hydrogen ion present in the tissue. Depending on the amount of hydrogen ion displaced, it will release energy when it comes to the original position. And that energy actually displayed in a particular scan. So radio frequency plus can be, different radio frequency plus can be used to get different type of picture for different structure. T1 weighted image, T2 weighted image, contrast sensitivity. We are mainly the IV gadolinium is used. These are some sequence used in optic nerve lesions. Most common is flare fluid attenuated inverse recovery, where actually CSF fluid in T2 image, which is appeared white in T2 image, it's make black, dark. When it make dark, surrounding lesions or any plaque lesion become clearly visible. Most important thing here, water signal from CSF become dark. On the other hand, this any pathological accumulation of water because of edematous condition will appear white, will remain bright. Diffusion weighted another sequence used for the orbit. Here actually we can find out the what restriction of water diffusion. This type of MRI can pick up any early ischemic lesion in the optic nerve or eyeballs before picking up by this conventional MRI. So fat separation, this is one of the very important MRI scan done for this optic nerve. 3D phase that. This is a 3D phase where you have seen that the nerve clearly visible, and this is the aneurysm which is compressing the third nerve. These are imaging image. You have seen the T1 T2 image. So here actually in T1 to T2 images, air become dark because of the less hydrogen. Bone also become dark due to little water. Lens is isoendous in T1, but hypon is T2. Most important thing, aqueous humor and vitreous dark in T1 and bright in T2. So contrast enhancement MRI, we have seen that there's some indication for contrast enhancement in MRI. Normally, these structures get enhanced because due to contrast. Choroid get enhanced because of high vascularity. Extraocular muscle also get enhanced due to lack of blood barrier. Pituitary gland, lacrimal gland, nasal mucosa, cavernous sinus. All these structures may get enhanced because of this contrast. So when this structure not get enhanced in MRI after contrast injection, that indicates probably contrast has not reached eyeball in a sufficient concentration. These are some salience of doing MRI in ophthalmic patients. Some cut section is very important for MRI. One is a quasi-corneal and another is a quasi-sagittal. If this in a normal axial cut, if you cut this normal, this is actually quasi-axial. This is quasi-axial. If you make a quasi-axial, because of oblique orientation of the muscle, this muscle will appear small. This will large. Here you see medial rectus appear small, lateral rectus appear large. It's sometimes mimic some pathology in lateral rectus, but actually this is because of orientation of the muscle. So if you get take a cut which is perpendicular to the long axis of the eyeball, this artifact can be removed. This is called quasi-coronal. And if you want to take this optic nerve scan, you have to make a quasi-sagittal scan, which is along the long axis of the orbits. So these are some lower axial cut of this MRI. You have seen that this is inferior oblique muscle and this is inferior rectus muscle. If you go slightly higher, you will see all the structure of the eyeball nicely seen. This is T2A2 image. You see the eyeball, optic nerve, as well as the retrorbital fat and the muscles. So this is slightly uppercut. You'll see optic nerve here. It's coming out from the optic canal to the optic canal. More uppercut will shows optic cut in optic chiasma regions. Then, of course, you'll see that most important one of the landmark is superior ophthalmic vein. That is also seen the uppercut of this axial section of this MRI. Corneal cut, this is from anterior to posterior. Anterior and posterior, slightly posterior, you'll see all the structure of the eyeball, and these are the ethmoidal sinus. If you go more posterior, you'll see the optic nerve, and that all the ending of the tenon of this, the muscles. Then if you go slightly more posterior, you'll see all cavernous sinus, where this at the wall of this cavernous sinus, you'll see all this nerve, third, fourth, and branches of trigeminal nerves can be seen on the lateral wall of this optic cavernous sinus. These are the MRI of pituitary gland. You see that this is the pituitary gland. This is actually an T2 weighted image. This is T1 when weighted image flare. This is the corneal sections. Optic nerve sheath meningioma. This is also this is optic neuritis. If you see this, you'll see that this is actually a fat separation. You'll see that the lesion here. This is optic nerve get thickened slightly. Here also, this is T1 weighted image. You see that whole optic nerve get thickens. Multiple sclerosis, you'll see that there's actually thickening of optic nerve, and you'll see some plaque here. This one. supraventricular plaques, and also you'll see some plaque in the spinal cord. This is mainly you see neuromyelitic opticus. These are some MRI, multiple sclerosis, emosi optic neuritis, and neuromyelitic opticus. In multiple sclerosis, you'll see isolated optic nerves, unilateral optic nerve involvement. A portion of the optic nerve will involve. In emosi optic neuritis, you'll see both the optic nerve get involved and whole of extent of the optic nerve get involved in emosi optic neuritis. In neuromyelitis optica, you'll see the involvement of the optic nerve in the optic chiasma. So this is there's another MRI of craniopharyngioma. Thyroid eye disease, already I have discussed this in CT scan part. Here, all the optic nerve get thickened. The whole extent is get thickens. Unlike this inflammatory myositis, where only a portion of the optic nerve enter to have the optic nerve get involved. Ischemic optic neuropathy. This is actually, as I told you, DW of this this MRI scan. You see that this early sign of the ischemia, which will ultimately lead to the ischemic optic neuropathy. This is actually an AIN, arthritic enteroischemic optic neuropathy, where there's a granulomatous inflammation of this optic canal lesions causing ischemic damage to the optic nerve. Traumatic optic neuropathy, of course, MRI is not the ideal source for traumatic optic neuropathy because there may be in foreign body, in metallic foreign body in eyeballs. CTs, if it is ruled by CT scan, then you can go for the MRI because optic nerve can be visible clearly with the help of MRI. You have seen that this is avulsion optic nerve. Optic nerve become discontinued from the sclera. This is same. This is sagittal section. The optic nerve get detached from this eyeballs. Idiopathic intraocular hypertension, you'll see that's some these optic nerve become thickened, but most important thing, you have to go for MR venography, where you can see some clot here. So idiopathic intraocular hypertension can indicate some serious condition in the sagittal sinus regions. Compressive third nerve palsy, already I have discussed Fiesta, how the optic nerve visible clearly. This third nerve become clearly visible with the help of Fiesta technique. This is the aneurysm, which is compressing the third nerve palsy. This is MR angiography. We have seen the aneurysm. This is MR venography. This is all about the neuroptomy. I think I have covered all these aspects of neuroptomy examinations. Thank you for your sharing.
Okay, thank you, Sanjay, for the elaborate discussion. Now that I am handing over the mic to the panelist, our honorable panelist.
Thank you, Sanjay. Can you hear me?
Yes, yes.
It was an elaborate covering of a very vast subject within a span of 1 hour. And it was very exhaustive as well as very informative. Yes. So I don't have much to add, but however, I'd like to stress upon that the neuro-ophthalmology patient diagnosis starts from the history. As soon as the patient comes into your chamber, you are observing him and you are trying to make a diagnosis, as well, starting from his posture or way of talking, etc., which you have stressed.
Yes.
And also another point I like to stress that as an ophthalmologist, we are at advantage to diagnose some of these very life-threatening disease, which many a time we are the primary doctors to diagnose some threatening disease and then to refer to the neurosurgeon or neurologist or appropriate department for tackling this dire disease. And another point I like to highlight, the neuro-ophthalmology is associated with neurology. So if we have a coordinated effort with or if we have a help of a neurologist, or we should work as a team to come at a diagnosis and management and also follow up of the patient. So these are some of the points I want to highlight. And it was, as I said, is a very excellent presentation. And this is for my points are these. Thank you.
Prashant, are you here?
Yes, yes. Yeah, I'm here.
yeah.
Sanjay, can you the slides so that can you stop slideshow? Then we can see everybody.
Yes, yes. Any question?
Yeah. Sanjay, just want to add 2 points. One is the importance of FFA sometimes.
Okay.
Especially in liver's hereditary optic neuropathy, if you want to differentiate it from other neuropathies, because there is a disc swelling. But in almost all disc swelling, if you do an FFA, there will be leakage of the dye from the disc, and it is a hyperfluorescent disc. But in liver's hereditary optic neuropathy, there is no leakage from the disc in FFA, and it is a very important finding. And one more thing in FFA is sometimes in diabetes, the term we use diabetic papillopathy. Am I audible actually?
Yeah, yeah.
Okay. Yes.
Okay, okay. In a diabetic papillopathy, actually, in an article in ISO, I remember I read that there is no specific condition like diabetic papillopathy. In diabetic papillopathy is a misnomer actually, but you see, if you want to differentiate it, if you it's a variant of non-arteritic AI1. If you want to confirm it, you can go for FFA. There will be delayed peripapillary choroidal filling because all the posterior ciliary nerves enters the eye around the disc. So that area there will be a watershed zone in FFA, and that can confirm that it's a case of non-arteritic anterior ischemic optic neuropathy. And I want to stress upon the examination of fundus and taking the photograph, color photograph of the disc. In papilledema, it's always confusing that papilledema is actually, if it is something else, or it is just papilledema, disc swelling. If you see the venous pulsation, as you all know, that 80% of the adults, we find venous pulsation. But if venous pulsation is present, no matter how big is the swelling in the optic nerve, it cannot be papilledema. And again, in children, 100% of the children, almost 100% of the children have venous pulsation. So, if there is no venous pulsation in children, but there is no obvious disc swelling, it can be marked as papilledema. I just wanted to add these 2 specific points.
Okay.
Sanjay, any
Thank you. Thank
comment on
you.
it?
Yeah, thank you, Prashant. You have rightly pointed out that FFA is a very important test for the in neuroophthalmology, particularly to find out any capillary dropout area in anion and ion. I have seen that in case of anion, this capillary dropout area is huge and large. On the other hand, anion will get a small sectoral capillary dropout. As you have said that this diabetic papillopathy is a variant of non-arteritic ischemic optic neuropathy. Of course, these opinions varies from author to author, because if you see the prognosis of the diabetic papillopathy, the prognosis is excellent, very good. Recovery is significantly much better than the anion. What happened in anion? It is because of the hypoperfusion of optic nerve head, either because of clotting or embolisms. Particularly, it is associated with some risk factor, including hypertension and diabetes. On the other hand, diabetic papillopathy, then most likely the ischemic pathology is not very significant as like anion. Therefore, prognostic outcome of this diabetic papillopathy is significantly better than the anion. That is my opinion regarding this.
Yes.
So, Dr. Dipangoda?
Yeah, thank you, Sanjayda, for this wonderful presentation. I have few observations to make. For example, what Nilupalda told about the clinical findings are very important, along with the examination that's a pertinent. Again, for Prashantada's question, Prashantada's question, papilledema and disc edema. Bilateral disc edema and papilledema differs. Papilledema means there should be raised intraocular intracranial pressure, then we have to say it's a papilledema. So CSF analysis has to be made, and if the CSF pressure is raised, then we call this papilledema. Now, Sanjay, a few things are there for the CT scan and MRI. My understanding is that if you want to see the cranium, it is the CT scan. And if you want to see the content, such as optic nerve or a chiasma or a pituitary thing, these are probably an MRI, which is the best. Now we see fluid attenuation inversion, which is a flare, is actually water suppression here, and it is basically for the optic neuritis. Optic neuritis with contrast is now Fiesta mostly hemicranial spasm is better picked up for the things, and for cranial nerve palsy we have to go for MRV and papilledema. Obviously, MRV and these are important. And if there is an aneurysm is suspected, then a CT angiography or MR angiography is important in such. So these are the, again, nowadays for multiple sclerosis, what is the McDonald's and the revised McDonald's criteria? You have shown beautiful pictures of the Dawson fingers and other in multiple sclerosis, and with dissemination of space and dissemination of time is there for these things. So I feel the clinical presentation, the histories are very, very important. The pediatric optic neuritis, then the infectious optic neuritis, differentiating from a demyelinating optic neuritis in the age-based things, and various other papilledema, disc edema, then temporal disc pallor. All these are very, very important in this situation. Thank you, Sanjay.
Thank you.
And thank you.
I think CSF analysis is also important sometimes, because in optic neuropathy, sometimes it could be because of some infections, sometimes infection of the brain or paranasal sinuses, there may be optic neuropathy. So MRI also pick up the paranasal sinuses to see in those situations. And CSF especially in case if there is a intracranial pressure is high, but the MRI didn't show anything, or CT scan didn't show much information, then probably we can go for CSF analysis.
Actually, CSF analysis is required in optic neuritis to find out the oligogland band of this problem. Optic neuritis. And another in MOP, this neuromantic opticus, we found this another type of this pleocytosis and increased polymorphonicular cells. And what Dipankar has said that the CSF analysis is papilledema. I personally feel that CSF analysis in the papilledema is very risky.
No, I'm not telling CSF analysis. I telling to say papilledema, there should be raised intracranial.
Yes. So what you have said, CSF analysis?
No, papilledema is indicated because it leads to the corneal herniation.
Yes.
So
CSF is absolutely conducted in papilledema.
Okay. Actually, I like to add something, because this is a class for mostly the juniors. So there, while we are talking about papilledema, we should also remember about the pseudopapilledema. So like optic nerve head drusen, or even hypermetropic eyes, or even some optic nerve head lesions, they may mimic papilledema. So then your other diagnostic procedures, like starting from the pupillary reflex, comes into play, and other methods which has been described by Dr. Sanjay, that will come into play. But if we look at the only papilledema, maybe we have to differentiate pseudo and actual papilledema. That's while diagnosing some of these cases.
I think optic the OCT helps a lot of understanding for the papilledema and pseudopapilledema.
Exactly, including FFA also can differentiate between drusen on the optic nerve head, etc.
Is there any PhD student? Huh? PG student, they have any questions regarding all these things? PG student there? Rajiv, any PG student is there?
Yeah, yeah. Actually, there are many PG students. They are participating here, and
But whether they
actually,
have
we
any
have covered
questions, or
everything.
should I ask them any questions regarding all these things? All this.
Actually, they are giving me some questions relating to transient visual obscurations. That is
No,
transient
let them ask these particular topics, clinical examinations.
clinical exams.
Yeah,
Oh,
then let them ask what I have told them about clinical examinations. If they have any doubt regarding all these things, that how to examine the people, these are very important, which
important point. Yeah,
things,
yeah.
points. How we should do color vision? What are the plate Ishihara plates? Pseudo isochromatic plates.
Yes.
So whether these are clear to them?
Yeah, I think they're very clear about it, and we can collect the questions from them, and I will definitely send to you. Before that, Sanjay, may I request Deepali ma'am to give some insight in this topic?
I don't know. I'm not visible on the video. Can you hear my voice?
Yes, sure, ma'am.
Yes,
We can
ma'am.
carry.
Yes, ma'am.
Okay. Well, that was a very nice discussion. Dr. Sanjay has given a very detailed
Thank you.
Because this is a topic which will really benefit the PG students. And well, one point, like a lot of discussions have been going on, and I think most of it is covered. But one point about the color vision, I want to ask the PG students. I think they are there, some of them, right? So you see, in the because mostly we do for color vision Ishiharas, particularly in the medical colleges. We don't have the other, systems.
The FM 100U test.
Yeah, 100U test. We don't have that. So, Ishiharas, what I find is that if you want to come to a diagnosis, you have described so nicely, we need that page where, like that information is given, which plate gives us what,
Yes.
sort of information you're going to get. But what I find is that mostly it is missing in most of the Ishihara's plates.
Yeah.
I don't know, the thing, who else is there? Rajan is there from medical college.
Yes, ma'am.
Yes.
So do you, in your Ishihara's charts is the chart, with the answers that is available? Because
yes, ma'am, there's a booklet actually in
no.
Ishihara.
That's what I'm saying. That booklet is mostly missing because the PGs don't know how to use it, and somebody will take it away to do the color vision testing, and then somebody will misplace it. And then what happens? It is difficult to come to a diagnosis because we get a lot of patients where you have to give the certificate them whether they are color vision normal or not normal. And then we need that chart. I mean, we need that booklet where, like which plate will tell you it is a deuteranopic or what sort of anomaly is there. And then we come to it is difficult.
Correct, ma'am. Yeah.
Do you understand what I'm saying? My point is that, you need that booklet.
Ma'am has pointed out a nice thing that we also face the same issue. And I want to ask Dr. Sanjay, he has made a wonderful presentation.
Yeah.
And to ask in a practical way, nowadays we are having many mobile apps where this Ishihara chart is also available. And which can be shown, and what's his opinion regarding this?
I don't think this will be very effective as the real Ishihara test. My personal opinion is that always go for the Ishihara testing with that this plate and do all the protocol as I have mentioned. I don't think the mobile apps, their illuminations, their this arrangement, and that the inclines of the image, particularly
contrast sensitivity,
all these things has to be kept
lightning,
I just want to add one point regarding whether Dipankar has said. He has rightly pointed out that soft tissue delineations, MRI is best. MRI, optic nerve evaluation, as well as to find out any plaque lesion in multiple sclerosis. But nowadays, these new CT machines, they can also pick up this soft tissue lesion clearly they can delineate the soft tissue lesion from the bone lesion if correct Hounsfield unit is used. So if you mention this, ask this radiologist to do that particular scan with that particular Hounsfield units, then they can pick up this lesion easily. For example, for vascular lesion, the Hounsfield unit should be around 40 to 100, something like that. So if you suspect a vascular lesion and if you ask the radiologist, then you do this CT scan with that Hounsfield, then you can pick up this lesion clip. That is most important thing. Even CT scan also quite useful to pick up a soft tissue lesion if it is done in a correct way.
So I have a comment on the Dikale ma'am's question, like Ishihara sir. So we always want that all PGs should have a direct or indirect ophthalmoscope or a 90, 90-day lens. That way, all PGs should have a Ishihara sir. In that case, the problem madam has raised will be solved.
Yeah,
Ishihara
that's very important, Prashanta. The Ishihara chart should be there with the optometrist. It should be there with the DNB student. It should be there with the consultant. They should check that thing, confirm what has been reported by optometry, other thing. Ishihara chart should be there with everyone. That's very important message.
So may I add one point, sir?
Sure.
Yes.
The price of the Ishihara, actual Ishihara cert, I think it's around 42,000, and you can have some copies in the pre-conference stalls. If the price is around 500 or 2,000. So, what is your view on that, sir?
Originally, it's 42,000. I am not aware of these things.
Yeah, that's it. That means the actual Ishihara's
maybe
going
yeah.
on with us. Only in the medical colleges we have the actual Ishihara.
Is there any difference? Is there any difference from original this?
Yes. Yes, there is vast difference between the colors and contrast and the background color. So the original is previously when I bought it, it was around 20,000, and it is very difficult to get. Now I don't know if it is 42,000. I do not know, but the local one, which are 500 or 2,000, these are of no. I don't think it is. These are of much use. And D15 and D100 are very good, but I think for a busy practice schedule, Ishihara is the way to go.
The most important part of this Ishihara testing is that we have to know what are the different cards are, and what is the purpose of different cards. There's actually 5 different cards. One is demonstration, hidden, transformations, vanishings, diagnostic, and tracings. We have to know the function and purpose of all the cards. Simply showing the Ishihara card is not going to serve the purpose. We must have the knowledge about these different cards.
Dr. RG sir,
most important thing is the record of the Ishihara. Every scoot should be recorded out of which number it has been seen. That should be right and left. It should be recorded along with the numbers. What Dr. Sanjay has shown. That's very important to document it and put in your manual EMR or in the electronic EMR. You can put that one. That is a very
Vijit, in your medical, whether they are doing any FM 100U test?
No. Password Munchal 100U test is not there.
The medical class should have at least FM 100U test.
No.
Because unless you do FM 100U test, you cannot diagnose proton of, return of, titanops. You cannot distinguish red, green, blue, yellow, black. Ishihara test can only pick up red, green. So
now, what about
the patient
D15?
come with all color blindness, if particularly for some diagnostic purpose as well as for service purpose, we want to know what type of color blindness. It is protandum, ditandum, titandum. Then we have to send this patient to medical college at least to find out all these things. Medical college should have at least FM 100 test.
That's a good point.
I have
Till now we only have this, right now also I'm sure I have retired from medical college, but I don't think we have the other tests.
What about D15?
I don't have any idea about D15. Do you have any idea about D15? I've never seen D15.
No,
Do you have any
D15
idea
is,
about D15?
yes, I have
Have you done
D15, but
D15?
protonab, deutonab, these kind of graphs are not possible to get in D15, but it gives you a better idea than type of color blindness than the Ishihara.
But I don't
D15
think
is not
D15
very
is as good as FM100.
no,
FM100 you must
no,
superior
no.
than D15.
FM100 is the best,
Uh,
but if you want to have a cheaper version, D15 is the, so you can try.
Only thing is that difference between an FM100 where you see not 100 hues, but we
yes,
see
yes,
85.
85, yeah.
Yeah,
Exactly,
and in
exactly.
D15 we see 15 hues. So naturally hue content are less, so it will be less reliable than FM100.
Exactly, exactly.
I have one query outside this color vision to Sanjay. So I have faced several patients with postpartum cortical blindness, and many of these patients almost I have lost some patients in follow-up, but most of these patients has recovered good. I mean, there was a good recovery, but the initial period is very stressful to the patient as well as to the doctors also who couldn't see any signs.
What sign? What
So,
sign?
yeah, postpartum cortical blindness.
What CNS? What CNS? CNS sign? What is it?
No, not CNS sign. They cannot see any signs.
Oh, any sign.
Okay, any signs. The fundus and everything. No macular edema, nothing. They have given history of recent delivery, and how to go ahead with this kind of patients.
You see that if you find the etiology of this postpartum optic neuropathy, there may be two reasons. One is inflammatory, and another is optic neuritis. I'm sorry, ischemic optic. Because of excessive bleeding in postpartum period, there may be non-arteritic ischemic optic neuropathy. So it is very difficult to distinguish these two conditions, whether it's inflammatory and IONs. So and again, you don't have a time to do all these tests to find out, distinguish these two conditions. The best way will be that you better go for a high dose of steroid in this case. Intravenous methylpenicidin followed by a course of steroid, oral steroid, as per the ONDT protocols. That is my opinions, and most likely, if this condition is inflammatory, it will improve definitely. Which patient regain back vision, and majority of these postpartum optic neuropathies are inflammatory. Unfortunately, some are ischemic. If these are ischemic, they are not going to improve.
Abhijit, whether you are asking postpartum cortical blindness or postpartum optic neuritis?
Kind of a cortical blindness, cause
a cortical blindness.
This
not optic neuropathy.
This condition, I actually don't know, because this condition does improve. As Sanjay has said, I didn't give any high dose corticosteroid in these patients, but this patient gradually improved over months of time, and got back their almost normal vision. But the initial period, initial 1 month or so, is a very stressful for both the physician also for the doctor. I mean the patient also. I have found several patients.
How do you know the cortical blindness?
I don't know about others whether they have faced.
How do you know the cortical blindness? Have you?
I don't know. I don't know actually.
You have to. There should be some criteria to diagnose the cortical blindness.
That's what I'm asking. How to go ahead with the investigation?
For example, cortical blindness.
You go for a perimetry test. You will get a hemianopic field defect with macular scarring.
I think this is.
If there will be normal people are on cortical blindness.
Now, postpartum blindness is a well-described disease, and it happens with dimness of vision, and rarely there may be total blindness. But however, as Sanjay has said, the recovery is slow, and it comes back to almost normal level. Probably it is inflammatory. But my question is whether pathology is in the LGB or in the optical cortex.
Cortical blindness means 17-18 areas of the cortex where there's a dual supply with the middle cerebral artery and the posterior cerebral artery. Now, this that because of the pregnancy, there is a load and there's a ischemic changes which can lead. But once there is a MRI documentation of cortical blindness, whether those changes, it's a debatable thing. but some subtle changes can be reversible once delivery has happened. Steroid is not indicated in those. The delivery termination of pregnancy itself lead to the improvement of those conditions.
Yes,
I think
agree.
postpartum cortical blindness is not the proper time. Postpartum optic neuropathy will be the proper time.
Yes, yes.
We are joining lately by Dr. Eskeri sir. Satyendaka sir, are you here?
Saityan has come just now.
No, I was little bit late.
No, I was expecting you.
I'm
No,
just listening. I'm just listening.
You were absent in my talks. Very
No,
unfortunate.
I'm there, but I am in a different mode now, in traveling mode.
So
That's why I kept it.
What about
Okay.
what he is doing now?
So I am going. I have listening Sanjay's lecture from the middle. But anyway, I know Sanjay. Why actually we have planned this kind of meeting, because neuro-ophthalmology is always a little bit neglected, and people try to just push the case. Okay, it doesn't seem like that this is my subject. So people don't want to do treatment, and also they are not aware of many situations. And keeping in that mind, so we have planned last year, last month, same way like for UVITs, we asked Dr. Dipankar to have some lecture and enlighten people. And this time we have selected Sanjay to have a discussion on neuro-ophthalmic tips for ophthalmologists. This is a subject almost neglected. So now today lecture, Sanjay is
examination point, this is most important.
Yeah, this is very important. And Sanjay he has given almost cover everything, and our panelists also given the inputs. I am happy that at least this kind of discussion will bring like more enlighten us with neuro-ophthalmic problems. And just to be a simple, only few things we have to suspect if there is a neuro-ophthalmic problem or not. Whenever there is some unexplained visual loss, we have to see if it's more. One is the color vision. Maybe Sanjay will be like, he'll give better explanation. Simple color vision, see the pupil and the disc. And if you feel that, okay, there is some suspicion, then a visual field test. I think most of the cases you can come to a diagnosis with your clinical judgment, and sometimes you need the other investigations. So in today's discussion, all these things has been covered. And actually, Ophthalmic Society of Assam, ARC webinar series we are starting, and we are happy that this kind of discussion definitely will help our postgraduate practicing ophthalmologists, and who are in the practice, they're also getting more information. And
Not necessarily postgraduate students,
chairperson and speaker also for this particular talk, and
best thing is when we come to a webinar like this, we should have some homework, and that gives the input. No, so most of the time we see the neuro-ophthalmic case. If it is a neuro-ophthalmic case, we are not very much we do not study too much of neuro-ophthalmic case. But at least for this webinar, we have gone through books and we have picked up some points. That way, we are involved with the subject. That's very important. That is another aspect of webinars.
Yeah.
Correct.
Correct.
Also.
Yeah. So we have
Yes.
thank you, Satyendaka sir. We have also our president joining lately, and SKG sir, Super King Goswami sir. Are you listening, sir?
I'm listening. Not joining lately. I was there, but actually, what happened? Neuro-ophthalmology, just like a subject of my PG. So I am really benefited by the Sanjay's nice lecture. One problem this is not with optic neuritis. One problem usually I face all the time. The diabetic patient, they are coming with Bell's palsy, and high diabetic patient, we cannot give a steroid, and we send the patient for physician consultation. Again, patient doesn't turn up, patient vanishes. This is a very, very big problem for me. Whether I should treat the diabetes pardon?
Yeah, you carry on, sir. You carry on.
So it's a tricky question, tricky decision for me whether I should send the patient for diabetologist or whether I should treat the diabetes my own. And now I have decided that as because I am a diabetic for last 20 years, so I know everything ABCD about diabetes. So now I start treating the diabetes and patient is with me. This is my personal experience. Anyhow, Sanjay and all the panelists, you have nicely highlighted all the salient features as if I am attending a PG classes today.
Thank you, sir.
So thank you, sir. Sir, we are running some sort
Thank you,
of
sir.
yes, time. Dr. G.S. Gogoi, sir, Gauri Shankar Gogoi, sir. Are you here, sir? Dr. G.S.
I have not seen.
Hello, Rajiv.
Sir.
Hello, Rajiv.
Yeah, I'm listening, sir.
Hello. Nice.
Thank you, Niranjan and all for organizing such a webinar. Yeah, actually, neuro-ophthalmology, usually peripheries, we don't give much importance on it. When in case we get any neuro-ophthalmic cases, usually we try to refer it to the nearest either neurologist, usually. So now I could get some of the points that yes, we can also go some of this test and all. So thank you, all our chairman, panelists, and moderator Rajiv. And
yes, sir. Thank you, sir. Dr. Rajan Gogoi, sir, is saying something.
Yes, Rajiv. I must thank Dr. Sanjay for having a very exhaustive neurological examination of the ophthalmological patients. So that neuro-ophthalmology part has been covered very well by Sanjay. I want to tell Sanjay that some clinical examination and investigation, radiological or other investigations are being mixed up, actually. We must know that clinical examination should be done first, and then only we go for some other investigations. So, and what type of patients should be doing at least what type of workup? So those things we should know, we want to know actually. So not all the patients of any neurological disease should be done every part of the examinations. So comprehensive examinations are required so many times so that we can avoid some other unnecessary excessive investigations. So that thing I should that should have been discussed. And other thing is that so many times migraine patients, they come to us as a neuro-ophthalmic patients. In those patients, how to go ahead? That I want to know from Dr. Sanjay. Sanjay, can you give some insight on this migraine patients?
Sanjay muted. Sanjay, you are muted.
Hello.
Sanjay, you are muted.
Sanjay, are you here?
Yeah, no, migraine will take another to this class.
Hello.
Another topic. Have you? You're listening?
Yeah, we're
listening.
Yeah.
So today's discussion is about neuro-ophthalmic examinations. What I have been given responsibility to talk about this neuro-ophthalmic examinations. Migraine will be a completely different topic.
Anyway,
different type of migraines are there. We have, of course, being
that's all from my
about the ophthalmic migraines. I do not treat migraine myself. Whenever I suspect migraine, I always refer the patient to neurologist. Let them treat this migraine, and their treatment will be better than theirs. So this is my opinion about migraine.
Probably Rajendra is asking whether we should confuse migraine with some neurological cases.
Yes, sir. Yes, sir. Actually, I want to add some point. Actually, being a junior myself, sir, please pardon me. But recently, I have a paper on sarcoidosis along with my anatomy friend. Then we found that the posterior communicating artery aneurysm almost present with migraine-like features. So being an ophthalmologist, we should, if there is a migraine patient, we should always suspect the vasculature anatomy of the circular pupils. It's a, I think you know better than me, but I just put forward my point.
Very nice information.
Just want to make one point. In migraine, if there is vomiting, migraine headache relieves. But if it is some neurological case, even after vomiting, the headache is not relieved. That is one of the differences.
So migraine is a migraine for the ophthalmologist also. But what I would like to share my personal views, but whenever there is a migraine suspect is there, so depending upon if the patient is very young or very old, then definitely I always take the help of my neurologist friend. And if the age is in between, and if they have got symptoms like migraine, which has been classical migraine, then maybe we can treat with some of the medication which has been prescribed. But I always like to take the help of the neurologist if possible, because they always come back and they are really a headache for the ophthalmologist also.
Third nerve palsy is one of the most common features in migraine, sir. Third nerve palsy. Hello. So we are Dr. Our GS. Dara শুনিছেনে নিৰঞ্জন দা?
শুনি আছো, শুনি আছো।
So we want to hear something from you.
No, it was a fantastic talk by Sanjoy Da, and a great sum up by all the panelists. So actually, in medical colleges, as Satyendra has told, that we get a lot of actually optic neuritis cases, bilateral optic neuritis. So, and also, so main thing is that as Satyendra has sum up, pupil examination, color vision, and should be examined properly. So that message should go to the PG students. And recently we had, Sanjay, can you hear me? Hello?
Yes.
Hello?
Yes. Please continue, yes.
Recently we get a lot of interesting cases in medical college. Recently we had a patient, he was 40, sudden dimness of vision. So we did MRI, everything, features of papillitis also. So he was hypertensive, not diabetic. MRI was then, nothing came up, and we had done a lot of investigations. But at that time, at time of presentation, his vision was very poor, and after methylprednisolone, his vision improved. So later on, now whether if we do the perimetry,
MRI.
MRI was done, nothing was there, substantive. So all investigations normal, except he was hypertensive. So now his vision is, it was a bilateral case of papillitis.
What is his age?
Around 45 to 46. So his vision has improved after methylprednisolone, but nothing substantive came. Now, any role of field analysis? Any role?
If you do the field test in multiple, optic neuritis, mostly you will get diffuse type of field defect. And there may be paracentral scotoma, and sometimes rarely you may get ultrasonic field effect. So you can do the field effect for the subsequent follow-ups. Otherwise, from treatment purpose, this field effect is not going to serve the purpose.
You see the
regarding
residual
that, regarding
But
your optic neuritis, come bilateral same at the presentation.
We done an MRI.
No, let me ask
Hello?
one questions. This bilateral optic neuritis come at same time, or this eyeball affected in different time?
No, same time.
If you have suspect bilateral optic neuritis, most likely it is a atypical type of optic neuritis. One condition called MOSI optic neuritis, myelin oligodendrocyte glycopathy optic neuropathies. And in this type of optic neuropathy, you'll get involvement of optic chiasma regions and some of the paracentral or paraventricular regions of the brains. MOSI optic neuropathy actually usually affect young children and adults. So if you suspect MOSI optic neuropathy, IVMP as per the ONDT protocol is much, but this MOSI optic neuropathy has a high recurrent rate. So if the patient comes with recurrence optic neuropathy, then you have to take the opinion of a neurologist. And we have one study called SAM study, which actually said that if you use interferon or Avonix injections that will reduce the optic development of multiple sclerosis from this emoji optic neuropathy significantly less. So bilateral optic neuropathy, you have to follow up the patient at a frequent interval. And if the patient comes up with recurrent optic neuritis, which is very common in these type of conditions, take your opinion from neurologist and do a detailed evaluation, including CSF analysis. And of course, with the help of neurologist and a combined effort of neurologist and ophthalmologist, we can start interferon or Avonex injection treatment, beta interferon. Regarding this field test, it gives some this clue about this extent of field effect, but usually it's improved with steroid treatment. It is not going to help the purpose of these treatments. That is not the important test for this type of optic neuritis. Most important thing is follow up and see whether it's come with recurrent optic neuritis.
Just Sanjay, just one simple point I want to highlight, that in discussion we have not talked about hypertensive crisis related disc swelling. It's a bilateral condition, and young adults with very high blood pressure, it is just a very typical condition. And
No, Prasad da, his
আপনার voice to শুনা নাই ভালকে আপনি কি কৈছে শুনা নাই
Prasad da.
Yes, yes.
Yes, his BP was BP was not very high.
Okay.
His BP was not very high.
Yes, yes. No, it's okay. But what I want to make a point is that in bilateral papilledema, disc swelling, in a young adult, we should go for BP check, because BP will be 200. BP will be 200 or 220 by 120, like that. In that situation, we don't have to go for all those investigations. Straight we send the patient as an emergency to physicians so that to take care of the blood pressure.
I agree.
Yes, yes. Okay, okay. Yes, that we have seen, but this patient did not have high BP.
Okay.
So he was.
This is clear-cut optic neuritis. No, your case was clear-cut optic neuropathy.
Optic neuritis, bilateral. It was bilateral.
That was responding to this IVMP treatment. No?
Yes, yes.
What was the age of the patient?
40. He
40.
said
Now,
45, 46.
Apart from MOG disease, no, there may be atypical bilateral optic neuropathy, which are due to the collagen vascular diseases. For example, rheumatoid arthritis can cause atypical optic neuropathy. So you have to keep in your mind if MOG antibody and aquaporin antibodies are negative.
What is the loss of vision in this case? It is chronic or sudden loss of vision?
It was a sudden loss of vision.
Case.
Yes.
It was sudden.
Yes, yes. It was a sudden loss of vision.
So this might be a this optic neuritis case, but in case of atypical optic neuropathy due to collagen vascular disease, vision loss may be slightly slow and chronic.
Okay. Thank you so much.
So actually we are now we are summing up. So any of the panelists or respected chairperson, if any want to give some more input, then please you can give, sir, ma'am.
Well, as someone was saying, neuro-ophthalmology, it was a very good thing which Dr. Sanjay has given for all of us, including the PGs, of course, but us also. I think all of us have picked up a lot of informations, because these are, as one of the persons in this thing said, that we usually shift it to some neurologist or other friends. So it was a good discussion. And I think Dr. Sanjay Burgohain said that this was mainly about the investigations, this whole this thing. But yeah, whenever we get such cases, we should also, history plays a very important role in coming to a diagnosis. The onset, whether it is acute or sudden or very gradual, and like age of the patients, like elderly people or younger patients. So all these things, of course, one cannot cover everything in this topic, which was dealing with the mainly about the evaluation. So I think it was very extensive, particularly the CT and the MRI, because like the details that you have described, Dr. Buragohai, about the various, like I think the man behind the machine will be very important, because how to ask for the CT, how to ask for the MRI, those are also important. So if we just write, usually the CT will be should get a CT, we should get an MRI. But you have very nicely elucidated, what sort of sections we need, what sort of, like what contrast should be asked for. So these are the important things, I think, when we are going to ask for the various investigations one should keep in mind. And I think everyone has benefited from this discussion. And what should I say? And medical colleges, like just now you said that 100 hue test. I think we should all, Rajan and who else is there? Hendik, Abhijit Hendik is there. And of course, Nilanjan is there. I think we should ask for those, improvement in our systems. We should ask for improvement in the systems.
Yes. Yes.
So I think, I enjoyed it, because it is nice to keep in touch with the academics. So thank you all.
Thank you, madam.
Thank you.
Thank you, ma'am. Dr. SKG sir, Goswami sir.
You could just end up, it is a very nice, and keep it continuing. But I believe and I feel that there should be more PG participation, active participation, not the question answers, that they will give a question and they will observe. And next time, at least the PG students should directly ask the speakers, they will be benefited.
Yes.
Actually, if I can make a point, if you want to get the PGs involved, you should get their names, like you should ask them to, tell their names, those who are
pre-registered, that should be pre-registered.
And that will make them more involved. Now, and then you should make it mandatory that at least few questions must be asked. Because PGs means there will be different institutes from which they will be coming. So, different institutes can be given some responsibility that your PGs should ask at least 1 or 2 questions.
Okay.
Even 1 or 2 questions should do from each institute. Because there are a lot of institutes now. The medical colleges, there are so many medical colleges. And of course, Netrala is there. And I don't know if there is any other doing DNB courses here in Assam. So that is my suggestion. Because unless it percolates to the PGs, all this very nice discussion, it will just go to waste. Because Dr. Buragohai has put a lot of effort in his presentation. So I think it should go to the PGs and help them,
Yes, ma'am.
So Nilanjan, please make a note.
Nilanjan, what the other people do, they do it. Registration is mandatory for active participation, such that they can get the link. Those who are registered, and they can ask the question, or they can have the active participation in that way.
Okay, noted. I will do next time that they are participating, but I was trying for their active participation, but somehow they gave a question link this time. So next time we will allow them to enter. We'll try to get two PGs from each medical college, and we will try to enter in the main faculty link. I'm thinking of that. That'd be better.
Okay.
Okay, Rajiv, I think this Antot people should say something. Antot people.
I think Antot coordinator is here. Can we? Can you do this for us next time when we the next third webinar? Mr. Jain, Rahul Jain is there.
Rahul Jain is muted.
Okay, so I will talk to them. I will talk to them. Hello.
Dr. A.K. Andik, sir. Yeah. So please convey a vote of thanks to the participants and our honorable speaker and the honorable chairpersons. So if you want to add something, please, you can add it.
Everything was nice. And thank you, Sanjay, for your wonderful participation. I would like to say thanks to Dipali Vaideo, Dr. G.S. Gogoi, Subroda, to be here and encouraging us. And a special thanks goes to Sanjay for his extensive preparation on this topic, and the panelists also, Nirupalda, Vasantada, and Dr. Dipankar, and all other participants, the PG students, and all the panelists, including the moderator, Dr. Rajiv, and at last, I want to thank the Anton Pharmaceuticals for their support in having this webinar, and we are going to see in near future also. Thank you all.
Thank you.
Okay, thank you.
Thank you. So we can conclude here. Goswami sir, Subhankar Goswami sir, can we conclude here?
Sir, Naini.
Sir,
Yeah, you can, yeah. Asu.
Final
We can
words.
conclude. Huh?
Final words.
The final words already over. So final word is that our next conference will be on 23rd. Midterm conference will be at Jorhat.
Yes.
23rd.
Smiling person, Prasanto, will be there, and other people will be there. So let us join in a big way. And we invite all of you to be there. Thank you. Thanks for everything.
Thank you.
okay.
Thank you.
Thank you. Good night to everyone. Thank you.
Night.
And thank you, Rajiv,
Good night,
for
good night.
nice moderation.
Thank you, Prashantoda. Thank you, everyone. Thank you, Dipali ma'am.
Okay,
Bye bye. Good night.
Thank you.
Thank you.
Good night.
Bye, good night.
Okay.